So in pernicious anemia, we basically have an autoimmune disorder with Hashimoto's thyroiditis, with coexisting diseases like Hashimoto's thyroiditis, or it could be type 1 diabetes in vitiligo and hypoadrenalism, which may coexist. And this would be then, and the antibodies most likely affiliated are the intrinsic factor antibodies. Then there is a high specificity of these antibodies, because 40 to because almost about the 40 to 60% of cases will show this intrinsic factor antibody positive in pernicious anemia patients. So if they are positive, then there is high positive predictive value of about 95%. And but however, if they are negative, if these are negative, then they do not rule out in pernicious anemia, and these are termed as antibody negative pernicious anemia patients. So these have high specificity, but the another and the incidence in the normal population is also and the incidence of pernicious anemia is very common in the um, United States and UK population. So they are also mostly European descent. They reflex testing of all low cobalamin samples in routine is expensive. So only those samples which have a positive high, which have a history of autoimmune disease and a family history suggestive of anemia and pernicious anemia, they are tested. So high titer. So in this case, since there is specificity of this test for uh, pernicious anemia, these testing of if there is a strong clinical suspicion of cobalamin deficiency with megaloblastic anemia and subacute combined degeneration of cord, despite a normal cobalamin level, reflex testing is still done, since high titer antibodies may interfere with the assay. And this assay is the automated chemiluminescence binding assay which is done. And here then we have mentioned that the antibodies can be both, which are detected are both the binding and the blocking type. The blocking type is the type 1, which is a blocking antibody that binds with the intrinsic factor receptor and therefore blocks the normal cobalamin, the normal intrinsic factor being secreted by the patient, which carries the cobalamin from binding to the receptors. And another one is the blocking antibody, which blocks the binding of intrinsic factor to its receptor, and the other is the binding antibody, which it attaches to the intrinsic factor and whether joined to cobalamin or not, and prevents its attachment of the intrinsic factor to the ileal mucosa. So there is a binding antibody and a blocking antibody. The blocking prevents the combination of intrinsic factor and cobalamin. This blocks the combination, and the binding, it binds to the intrinsic factor instead of cobalamin. So this binds there instead of cobalamin, and therefore prevents the attachment of the intrinsic factor to the ileal mucosa. And these are found in the sera of around 55% for type 1 antibodies and 35% in cases of type 2 antibodies may be found. And if these antibodies, these intrinsic factor antibodies, cross the placenta and cause temporary intrinsic factor deficiency in the newborn infant as well. So patients with pernicious anemia, they show a cell-mediated immunity. So there's a cell-mediated immunity to intrinsic factor, and the intrinsic factor antibodies are rarely found in conditions other than pernicious anemia. So intrinsic factor antibodies, when they are positive, they are specific. They have a high specificity for pernicious anemia, and we have now discussed also that they are mostly the IgG type of antibodies. Two types: the blocking and the binding. The blocking, they prevent the binding of intrinsic factor with cobalamin, and the binding, they bind to the into the intrinsic factor at the site where cobalamin should have been bound, and they prevent it from binding to its receptors in the ileal mucosa. So when they are present, they are highly suggestive of cobalamin deficiency and pernicious anemia, and they should be detected, and if there is a strong history of autoimmune disease like thyroid toxicosis or myxedema and Hashimoto's thyroiditis or diabetes mellitus, and also in relatives of patients with pernicious anemia, it may be present. And they reduce the absorption of dietary cobalamin by combining with small amounts of remaining intrinsic factor in the gastric juice. And because of this, these will cause these antibodies then therefore cause low levels of serum cobalamin. But even if the serum cobalamin level is normal, then we still need to reflexly test for them, because sometimes the high titer antibodies could actually have given this false normal serum cobalamin level. Then there are the gastric parietal cell antibodies. These gastric parietal cell antibodies are present in the sera of almost 90% of the adult population. And these they have shown that this has a high specific, the intrinsic factor have a high specificity, the intrinsic factor antibodies, but this have value of 95%, whereas the parietal cell, gastric parietal cell antibodies, they have a low specificity. And they are present in almost 90% of the adult population with the parietal cells, but are also present in 10% of normal individuals. So 80 to 90% of pernicious anemia patients, but also in 10 to 16% of normal individuals, and mostly in female subjects age over 60 years. So they have been found to be present. So this is, they have low specificity. And these antibodies are also found more commonly in patients with simple atrophic gastritis. Also, they may be found in simple atrophic gastritis may also show parietal cell and gastrin receptor antibodies. So they're not anti-parietal cell, gastric parietal cell antibodies, and gastrin receptor antibodies may also be there. And the parietal cell antibody is directed against the basically the gastric proton pump, the alpha and beta subunits of the H of the gastric proton pump, that is the hydrogen potassium ATPase pump. So the hydrogen potassium ATPase pump, there is these antibodies are directed against that. The intrinsic factor antibodies in we had read were those two types. Those they could be either the blocking antibodies that block the combination, then binding antibodies that that prevent the binding of the intrinsic factor to its ileal receptors. And these parietal cell antibodies, they are directed against this proton pump, this hydrogen potassium ATPase proton pump, gastric proton pump. And the sera of pernicious anemia patients may also contain an antibody to the gastrin receptor also, but they are not this is not being tested. So they will cause gastric acid achlorhydria, and progression to pernicious anemia may occur in patients who have this gastric parietal cell antibodies. Now, in the past, a proportion of low cobalamin normal and those antibody negative pernicious anemia, the Schilling test was done for them, but they have advised that this is no longer basically not necessary, because the holotranscobalamin levels cover most of this defect, and also because the use of radioactive cobalamin for this testing was very um, was sort of has become obsolete. And so upper GI endoscopies are done now instead of these chilling tests. Mostly they go for upper GI endoscopies, including gastric biopsy, to confirm the diagnosis and to exclude gastric neoplasms. Basically, gastric this will help not only to confirm the diagnosis, but at the same time it is also sort of helpful in diagnosing those patients who may be at risk even of having sort of a gastric cancers in association with this um, infection of pernicious anemia or chronic gastritis. So this gastric biopsy, what this gastric biopsy shows is basically atrophic gastritis that is in the body and the antrum. We know this body and the fundus. The antrum is paired. The body and the fundus, they shows this atrophy of all the layers. And the gastric element, the glandular elements are that is the parietal cells and the chief cells, they are replaced by the mucosal cells. So there's intestinal metaplasia, and there is mixed inflammatory infiltrate. That is, there's a lymphoid and a plasmacytic infiltrate in the lamina propria, which these CD4 positive T cells, they actually cause a fast mediated dependent mechanism of gastric mucosal destruction that leads to this form of uh, uh, this form of atrophic gastritis. So this is not, but we had mentioned earlier that in fact even in patients with simple atrophic gastritis, gastric parietal cell antibodies may come out to be positive. So a more likely test nowadays is that you do these intrinsic factor antibodies and the gastric parietal cell antibodies, and then you correlate. And we also go for simultaneously holotranscobalamin and methylmalonic acids levels are also done. And Based upon this test, if we have high level of suspicion that this is pernicious anemia, then gastric endoscopy is done, which would then actually show this chronic atrophic gastritis, and also rule out the increased risk or slightly increased risk of gastric carcinoma that may be associated with this. So it would, in a way, help in the um, management of these patients. And along with all this, pernicious anemia patients, this it has not been mentioned here, but another sort of a this is the actually the test that would need to be done in the anemia workup. But along with this, pernicious anemia patients are often they often more often by chance in patients they have this deficiency of mm, so basically patients who have this IgA deficiency, mostly they are the patients who end up most often end up with the diagnosis of pernicious anemia. That is, pernicious anemia is found more often than by chance in patients with the IgA deficiency. So there is a link between IgA deficiency and pernicious anemia. And also if the patient has so there could be even, so if we go if those patients who do not clinically suggest features of pernicious anemia, if their tests come out to be positive, then and other sort of diagnostic tests that we may do are IgA levels to detect IgA deficiency. So other IgA tests that we do are IgA levels, or which may show IgA deficiency. So there could be selective IgA deficiency or a complete hypo gamma globulinemia. So these subjects, they resemble others with the pernicious anemia, except that they often present relatively early. Now, those with this hypoglobulinemia, they present they are actually early presenters of pernicious anemia. So if we do not have all the signs of autoimmune disorders in those patients, which is suggestive of clinical picture of pernicious anemia is not there, but the tests for intrinsic factor antibodies, they are coming out to be normal. So we can correlate it with the gamma globulin levels. This would suggest an early form of the disease, and they have a lower incidence of serum intrinsic factor and parietal cell antibodies, and may show intestinal malabsorption. They also have history of recurrent infections. So the gastric lesion is similar to that in other cases, except that the plasma cells are absent from the infiltrate inflammatory infiltrate, and the antrum is involved. So another case that goes with the pernicious anemia patients who have this